So who is a professor at the Lucas Center of Imaging in Stanford University, and where he has been faculty since 2009. He has a background in engineering, medical biophysics, and imaging science, with a graduate degree from Stanford and Toronto. And he did his postdoctoral training at UCSF, and he made important contribution involving the development of MRI technology and clinical applications of the high field MRI. He is going to speak about segmentation and quantitative volumetry of thalamic nuclei using the ThALAmus algorithm, which you have heard already before. So now the floor is for Brian.
Thank you very much. Can you hear me and see the slides okay? Great. All right, so I'll dive right into this. You've heard, thank you very much for this wonderful, outstanding workshop. Manoj, thanks for the invitation to speak, and for all of you to have organized such a great meeting. I've learned a lot, and there's been plenty of discussion about ThALAmus and other segmentation methods. I'm going to focus on the use of the ThALAmus algorithm. In several applications, a couple of clinical applications and a more basic science application of study of brain atrophy and healthy aging. So you've seen this slide presented by a few people before, and this sort of encapsulates the beginnings of our work in the development of the white matter nulled MP range method, at least our variation of it, and the ThALAmus algorithm. I show this, especially want to point out the really fundamental contributions that both Manoj Saranathan and Toma Turdias made to this work. Toma had been doing a one-year sabbatical, if you like, at Stanford at the time in the 2013 timeframe, and Manoj was working in my group at the time. And combined with this graduate student, Jason Su, this was like the perfect storm for thalamic segmentation development. Those three really have made fundamental contributions. Manoj especially worked on the pulse sequence, looked at a lot of optimization of parameters to highlight and studying signal to noise ratio, contrast to noise ratio in these white matter nulled MP range sequences. Added some special features for case-based ordering that made the sequence even better with motion robustness, etc. And we've been using his developments of this white matter nulled sequence since then. Toma was looking over Manoj's shoulder at the time and said, "Hey, wait a minute! I think I can see thalamic nuclei in these images," and that really began his process of first manual segmentation guided by the Morel Atlas, and then that later led to the development of the ThALAmus automated segmentation algorithm. And speaking of which, this was the work of Jason Su, a graduate student in my group. And one of the things he had done was to say, well, let's look at one subject, and he was familiar with some of the multi-atlas label fusion methods developing at the time, and said, let's look at a 20 subject average brain. And these are even more spectacular with regard to seeing contrast and structures within the thalamus. And that led then to the development of the ThALAmus algorithm, a multi-atlas label fusion technique by Jason, which involves 20 brains in our case that represent the training set. These had all been manually segmented, all 12 of the thalamic nuclei by Toma. And then those brains are registered and averaged together into the template. What Manoj has done more recently, he's really the principal further developer of the ThALAmus algorithm. He's focused on cropped versions of the ThALAmus, whereas the original version of ThALAmus used the whole brain. Then these an individual incoming brain is registered to the template, and a multi-atlas label fusion operation done to come up with the final parcellation. One thing that was in the original ThALAmus paper was a comparison using the DICE overlap metric between the ThALAmus and the free surfer algorithm. We've been fortunate in having all of this data that had manual segmentation, all of it done by Toma, and some of it done after the original ThALAmus algorithm was developed. for example, in some patients that were being looked at with essential tremor. So there was, we made use of some of this data here to show the DICE comparison, and that shows the thalamic nuclei organized from the whole thalamus and then going downward in decreasing volume. So the largest nuclei at the left and the smaller nuclei at the right. And so the Thomas algorithm has a higher DICE coefficient and DICE, and therefore is more accurate with respect to the manual segmentation in the free surfer algorithm. And this was highly significant across, and more significant at the range of small nuclei, as you can see here. I was speaking about this with Vinod recently, and he reminded me that similar data was in his group's paper in their first deep learning approach to doing thalamic segmentation, where they compared Thomas and free surfer in a group of healthy subjects and a group of MS subjects. So we like the Thomas algorithm. We like our version of the white matter null empty range, and we've been using it in a few applications since that time. One of the ones I wanted to talk to you about today is actually one of the newest results we have. This is a project in the use of white matter null imaging and other forms of imaging to act as guides to surgical planning for deep brain stimulation and traumatic brain injury, which is maybe a rarer application of deep brain stimulation. This is a study that's led out of Cornell University by Nico Schiff. The principal neurosurgeon is Jamie Henderson at Stanford. Chris Butson is a bioengineer who does the virtual DBS modeling that you can see here. So we combined good quality white matter null imaging with best possible diffusion imaging that we could get in these patients that are all traumatic. They're all moderate and severe traumatic brain injury patients, so that we combine a structural and a DTI-based approach here. The structural images were segmented by Thomas into the thalamic nuclei, and the DTI images we use for tractography to define fiber tracts of interest. In particular, we're interested in the CL nucleus, the central lateral nucleus of the thalamus, which is the target that Nico Schiff has been studying for many years in traumatic brain injury and minimally conscious state. And so he believes that's the correct target to treat these TBI patients. But also the fiber tract known as DTTM that passes through CL, coming up from the brainstem, is another form of a target that we're after. So we want to treat this fiber tract as it passes through CL. And the study involves biophysical modeling of the effects of the DBS electrodes, which is all done pre-surgery, so that we can use all of this imaging and modeling to guide the placement, as well as the choice of the active electrodes and even the voltage levels or current levels on the electrodes. A little bit more detail here. So here's the results of Thomas. These are not all the nuclei, but some of the relevant ones shown in the axial plane. And you can actually see the pre-surgical or initial placement of the electrodes here, maybe best seen in this coronal movie here as I'm panning through the coronal slices. You can see we're intending to place the 4 contacts of each of the bilateral leads that are shown in green here in the lateral wing of the CL nucleus, which is shown in red. And we'd like it to, one of our targets is the tip of the electrode. We'd like to place it at the junction between CL and the CM nucleus here. But we want several of the electrodes in the CL in the lateral wing. So this is generally leads to a transventricular approach to placing the DBS electrodes. It's a bilateral leads, as I mentioned, in the lateral wing of CL, a tip at CL-CM, and we call this a vector-based targeting approach. That's a concept where it's not just a point in space we're hoping to target, but a point and a direction, the direction being defined by the DTTM fiber tract. So how do we do that? Well, we register the white matter null and the DTI images together. We define the DTTM fiber by defining regions of interest, the seed regions in the brainstem and the CL as a filter, so the fibers have to pass through the CL nucleus, here shown in blue. So that leads to the fiber rendition of the DTM fibers. We place a virtual DBS electrode at the point, with its tip at the location I mentioned, and optimizing the angle to maximize activation of the DTM fiber tracks. We model the effects of this activation in the prefrontal cortex by looking at fiber activation profiles as activated by each of the 4 contacts, C0, 1, 2, 3, as you can see here, depending on the voltage applied. Then we take a look at other fiber tracks because we want to avoid certain regions. So here, fibers passing through an adjacent nucleus, and we can actually model the effect of fiber activation. So we get avoidance regions and target regions in our activation profiles. And we go on and maybe put a second set of avoidance fiber tracks to be avoided. These might be MD fibers, for example, or CM fibers. And so 2 different avoidance regions here. We might look at this and say, well, we're getting too much activation of the to be avoided yellow fibers. And so we might then adjust the plan. So the final plan might have an adjusted lead location that moves the lead away from the yellow fiber tracks. And the final lead location then is some optimization or compromise position where we try to maximize target activation and minimize avoidance regions. So here's an actual subject in our study, just a movie through the thalamus rendition and in the coronal plane. And so let me stop this and run you back through. So now we see the initial plan in green. Those are the 4 contacts that I'm panning through, and the final contacts in white. And we obtain those by doing a 30-day postoperative CT, segmenting the CT and finding and then registering that back to the preoperative MRI. So you can see we missed a little bit, especially on the right side here. The left side was better. But we're a few millimeters off, and the surgeon thinks that's a pretty substantial miss. We learned later in the study that this had to do with brain shift that occurred. The left side was typically implanted first, and by the time he got around to doing the left side, there was enough brain shift to cause this amount of, so that can be corrected in future. But by and large, we were very happy with the resulting placement into the CL nucleus and paralleling the DTTM fiber tracks. And so we've done actual 5 subjects in this Century-S trial, which is an NIH Brain Initiative funded trial. It's the first human study of DBS implantation in moderate to severe traumatic brain injury to remediate impaired global function, impaired cognitive function, I'm sorry. We found that white matter null imaging in the thalamus, I actually call this the thalamus plus algorithm because we added the CL nucleus into the list of thalamus nuclei as sort of a hybrid add-on to the algorithm. And the DTI tractography. So these methods, these imaging methods were essential to identifying the target. We were successful in implanting all 5 of these subjects into the target that we were after, and that we found that this was a safe surgery and not associated with abnormal sensations or movements. And principally, the finding, which is just sort of hot off the press, as we've just finished our final subject a couple of months ago, we have found a marked improvement in performance on the primary outcome measure. We have various measures of executive function in the study, from the pre-surgical baseline to the end of the 90-day treatment phase for all 5 subjects completing the study. So this is really dramatic new information about DBS as applied to traumatic brain injury. So now I'd like to mention a few things about another treatment trial that we were involved with, and that is the use of MR-guided focused ultrasound to treat essential tremor. So I won't spend as long on this, just to mention that white matter null imaging is also very useful in this case of focused ultrasound ablation. So T2 weighted images is commonly used, but you can see that in the white matter null images that are done after the focused ultrasound ablation, we can find the ablation zone. We can see very clearly a core and a penumbral zone of the ablation, which we've made use of in defining these different regions. This is a manually segmented core and penumbral zone of the ablation region. And so this, combined with the ability of white matter null to, and the either manual or automatic segmentation of nuclei, was very useful in studying the effects of focused ultrasound treatment for essential tremor, trying to target the VIM nucleus. But particularly what we used it for was a retrospective analysis of where we ended up and what we might use this retrospective analysis for to find an improved target for the future. So in this case, we registered all of the data together. We did some 7T pre-treatment imaging, some 3T post-treatment imaging, put this all together into register over the pre-treatment 3T. We also took a bunch of other subjects and created a study-specific template. We made use of this common space to study ablation metrics and effectively resulting in something like this. A probabilistic lesion or probabilistic target was created across the 14 subjects in this trial. So this region kind of represents the statistical definition of the ablation that was actually achieved. And then we were able to overlay this on top of the ThalaMus segmentation and find that here we are at the bottom of the VIM nucleus. And we were able to correlate the overlap zone for each individual subject's ablation core over this probabilistic target and find that this was correlated strongly with outcome on the clinical score for these essential tremor subjects. So this is a way of making use of this kind of imaging and study-specific templates, probabilistic targeting, to find perhaps a more optimal target. Where exactly in VIM should we go in the future for this kind of treatment? And my final application I wanted to tell you about was in a more basic neuroscience area. That's the study of structural atrophy in healthy aging within the thalamus. So in this case, we took 198 cognitively unimpaired adult participants with the ages 20 to 88. We used SAMSEG, which is one of the FreeSurfer suite of tools, to segment the whole brain, particularly outside of the thalamus, but including the thalamus as one of the structures from T1 images. And when we evaluated age-related atrophy for 11 of the SAMSEG structures, and they're shown here. We also used the ThalaMus algorithm with our white matter null imaging, which was obtained in this case at 70 on all of these subjects. And we evaluated 10 of the thalamic nuclei from the ThalaMus algorithm. So this sort of encapsulates the kind of data we get. We're plotting the structure volume for the 11 SAMSEG structures and the 10 plus 1 ThalaMus nuclei plus the whole thalamus here. So you can see over the age range of the adult lifespan, we generally get significant atrophy, but a variable amount of atrophy. The red and black lines here show the model fit we have. So we're fitting this to a nonlinear model, but most of the data fits quite closely. It's pretty linear over the age span, and red for right hemisphere and black for left hemisphere. Maybe one thing of note is the lateral ventricle, which is one of the structures that comes out of SAMSEG, has the expected increasing volume with age. It's actually quite a strong and nonlinear increase, especially in the 60 to 90 age range here. But maybe especially interesting is the thalamus and the thalamic nuclei. And so their rates of atrophy are even higher than the rest of the brain. And it's interesting to look at the qualitative results, but what we did was extract the average atrophy rate as a % change per decade out of these data, and plotting that here. So just move this. The rate of volumetric change per decade, in percent per decade, is shown here. I show all of the 11 SAMSEG structures on the top side. The whole thalamus, which is sort of in common between SAMSEG and the ThALAMus structures in the middle, and all of the thalamic nuclei out of ThALAMus here on the bottom. So a couple of interesting points. First of all, you see the positive change for the lateral ventricle, and generally the negative change or atrophy for everything else. But I thought one thing that's of very great interest is that the whole thalamus has approximately the highest age-related atrophy rate of all of the brain structures that come out of SAMSEG. Only the nucleus accumbens is approximately equal to the whole thalamus. But then, even more interestingly, once we start going inside the thalamus, we see that atrophy rates for individual nuclei are highly heterogeneous, ranging from near zero, for example, the VLA nucleus, to more than 10% per decade, for example, for the AV nucleus. As you can see, running down this range of atrophy rates. Here again, black is the left hemisphere and red is the right hemisphere. So there was no significant hemispheric effect. There's little significant gender effect. There was some statistical significance for one of the thalamic nuclei, the CM nucleus, but not much else. There was a significant regional effect, and this was very interesting, and I want to show you one also very new result that relates to the regional effect, and particularly given some of the comments that Toma just made in his flash talk earlier. So in speaking about this with Toma and sharing some of this data with him, he mentioned his work in MS related to proximity to the third ventricle. And so what we've done is group our nuclei according to adjacency to the ventricle, any ventricular surface, versus not adjacent. So this is approximate, this sort of definition, but these are the nuclei from the Thomas algorithm that were organized into these two groups, adjacent and remote from ventricle. And then if we look at atrophy in according to this, split into these two groups and divided by decade across our subject population, first of all, we see the very strong atrophy over the age range, resulting in almost 4 standard deviations of fall off of volume by the 80s range. But in the 60s and 70s, and I would probably also in the 80s, we see a significant difference between adjacent and remote. More atrophy in the adjacent nuclei compared to the remote nuclei in the older age groups. So we've seen from this study that the whole thalamus has among the highest age-related atrophy of all brain structures. There's a wide range of atrophy rates for the thalamic nuclei, but they are even higher than other brain structures. About half of the thalamic nuclei are atrophying at a greater rate than all other brain structures, which are typically less than 5% per decade. I've mentioned the lack of significant hemispheric influence, not much gender influence, but this interesting correlation between atrophy and proximity to ventricle surface. This is consistent with the hypothesis that that's coming from the MS world, and looks like a little bit of literature in TBI as well, that there may be CSF mediated factors that lead to damage. Lesions occur close to ventricular surfaces, and atrophy is known to preferentially occur near ventricular surfaces in MS and TBI. So ours looks like the first finding of something like this in healthy aging. So I just want to conclude by saying that white matter null imaging and Thomas are providing high sensitivity detection and accurate quantification of thalamic nuclei. We've demonstrated the value of these tools for DBS planning in TBI. We're just starting a new project in epilepsy and focused ultrasound for essential tremor. I think these are very valuable tools also for studying basic science questions like age-related atrophy of thalamic nuclei, testing novel hypotheses, for example, the proximity to ventricle hypothesis in healthy aging and disease processes that affect the thalamus. I especially want to thank the groups that Jason, the group of people in my group, Jason, Unyoung Choi, former group members Manoj and Toma, and my collaborators at other institutions for all of this work, and thank you for your attention.
Thank you for the fascinating talk.